Morning, everyone. Hi, my name is Chaim Bell. I'm the Chief of Medicine here at Sinai, and it's a special day here at Sinai. Today is the Barney Barris lectureship, the annual Barney Barris lectureship. We have Dr. Ophira Ginsburg as our special guest. I'm just going to read the land acknowledgement. I'm going to say a few words about Dr. Barney Barris, who is quite famous throughout University of Toronto, as well as Sinai for example, the Whiteman Barris Academy. But Harvey Schipper, who is one of his, was a former chief resident here, is an oncologist at St. Michael's Hospital, and was one of Dr. Barris's chief residents, is going to speak a little bit about Dr. Barris and the impact that he had on him, as well as the impact he had on others. But first, I'm going to start off with our land acknowledgement. And today we want to begin with an acknowledgement of the land on which we work, study, and live. We recognize that many Indigenous nations have longstanding relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. Land acknowledgements, of course, are only a starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. I also like to take that opportunity to just reflect on our own family's journey to Canada, and just to reflect on what that's meant for us personally and our families in general. So, welcome to Grand Rounds. And there we go. What I wanted to do is first talk about Dr. Barris. Just to give a quick overview, Dr. Barney Barris was born in Toronto in 1921, graduated from the University of Toronto, Faculty of Medicine in 1944, completed his internship soon thereafter. He left Toronto soon after his internship because there were no spots for any people to do residency positions in internal medicine because he was Jewish. At that time, all residency positions were closed to anybody who was Jewish. And that's part of the reason why Mount Sinai was begun in 1923, which we're just following our 100th anniversary. He returned to Toronto in 1951 after completing his internal medicine residency at the University of Minnesota. He became chief of medicine at Mount Sinai Hospital in 1964. Soon after we realized our full university affiliation. He was known around Sinai as the doctor's doctor. He was renowned for his outstanding clinical acumen and exemplary teaching. He served as chief of medicine until 1977 and continued to practice and teach thereafter. He's been credited with helping establish the academic foundation of the department. As I said before, the Whiteman Barris Academy is partially named in his honor. On a personal note, I only met Barney a couple of times and only really in social situations. So I'm really looking forward to a talk, to a bit of an introduction by Dr. Schipper, who will talk a little bit about Dr. Barney Barris and what he meant to him and to many of them around, and many people around him.
Well, thank you very much, Chaim, for the invitation and the opportunity to say a few words about Dr. Barnett Barris, who was my teacher, mentor, and friend. It's a reflective time for me, actually, a full half-century since Michael Gordon, the iconic geriatrician, who I understand is joining us on Zoom, and I shared the chief residency here. It's a bit eerie being at the top of the names list of the plaque of chief residents outside the door here, by virtue of the undeniable qualification of age. In fact, a few years ago at our hematology-oncology rounds at St. Mike's, in the days when we met over a meal to learn together, one of my colleagues, the late Dale Doughton, decided to introduce me to the group as Dr. Barris resident, of the Whiteman Barris Academy. A young faculty member looked at me rather quizzically across the room, paused with some fascination, I guess, and then said, "Were you alive then?" Barney carried himself with a quiet confidence that came from extraordinary powers of observation, analytic brilliance, and deep humility. As was his principal teaching tool, I'd like to present a case. It was a man in his 60s, a diagnostic enigma. He had episodic spotty rashes, transient episodes of renal decline and proteinuria, moments of confusion, and mild focal neurological signs that came and went. Many systems evanescent. Michael and I were sent to see him, following Dr. Barris's admonition not to read the chart first, to preserve independence of mind. We took a history and examined him carefully. Something multisystemic was going on, but we didn't have an answer. We brought Dr. Barris to the bedside. We reviewed our findings. He led us to the notion that this might be something vascular. He then asked, how at the bedside could you visualize the microcirculation? The answer was by looking in the fundus of the eye. We looked, and there it was, a highly refractile cholesterol crystal traversing a retinal artery. How to prove the diagnosis, he asked. When the rash next appears, do a biopsy and make sure to tell the pathologist what you're looking for, because usual staining doesn't help. And sure enough, that's what we found. We encountered a few other cases, and the paper we wrote in the Canadian Medical Association Journal in 1975 was the first systemic description of cholesterol atherembolic disease. It should be called Barris disease. What are his lessons throughout my career? No matter the new diagnostic and treatment technologies, hone your human bedside skills to the highest degree. Never set aside your intellectual curiosity, for each patient is an invaluable clinical trial whose outcome depends on your ability to see the whole picture. The tests are an adjunct to your analysis. Each test should provide a fork in the road, helping to resolve your careful consideration. The tests may change, the diagnoses may come and go, but it's all about the person who is the patient, not the disease named by a test. Finally, I'm particularly delighted that the Barris lecturer this year is Ophira Ginsburg, a student of global health. And that goes back to another lesson from Dr. Barris. I was a senior resident at Mount Sinai before becoming chief resident. Dr. Barris made it possible for me to spend some months at the Kenyatta National Hospital in Nairobi, Kenya, framing the proposal by saying, there's much more to medicine than what goes on University Avenue. I would be a better doctor for the experience. And in another Dr. Barris way of knowing his residents, he said that since photography was my hobby, I should return with a teaching collection. I did, and as it happens, I drew upon it a few weeks ago. And his encouragement, that period of time in Kenya, led me to work with the cancer unit at WHO on Dr. Jan Sternfeld. Barney kept an eye on me for many years. Sadly, he developed Alzheimer's disease, but somehow retained the fineness, the quiet dignity, and as it happened, the ability to play what bridge players, which I am not, described as a wicked and resourceful hand. That was the quiet, professional essence of Barney Barris, a teacher of teachers, a consummate clinician of a sort rarely seen these days, and a facilitator of great dignity. This hospital is a lasting testament.
Thanks, Harvey. And from one trailblazer to another, we've had some outstanding outstanding professors that have come over the years for the Barney Barris Lecture, and Ophira continues along those lines. Ophira Ginsburg is a physician scientist and global health leader with over 20 years of experience in cancer control and women's health. She specializes in cancer genetics, prevention, and early detection with a focus on advancing equity through research, policy, and implementation. She earned her BSc and MD from Queen's University, MSc from McGill, and completed postgraduate training in internal medicine and medical oncology here at the University of Toronto. She's a fellow of the Royal College of Physicians and Surgeons of Canada. She's published over 150 papers, including peer-reviewed articles and commentaries in Lancet, JAMA, and Nature Medicine, and has delivered invited lectures at the U.S. National Academy of Medicine, the Royal Society of Medicine. She's the founding chair of the Lancet Commission on Women, Power, and Cancer, and a 2022 recipient of ASCO's Humanitarian Award. She's currently consulting for Médecins Sans Frontières and will soon serve as Provost Visiting Professor at Imperial College London. Looking forward to your talk, Ophira.
Thanks so much. It's really such an honor to be here to give the Barnett Barris Lecture, and I recognize that I'm standing on the shoulders of giants here. And one of those giants is here, my sister, which makes me very nervous, Shipper Ginsburg. As our other family members, Stuart, my brother-in-law, and my niece, Maya. Yeah. Okay, so I think this froze. All right, there we go. So cancer actually lays bare the fractures in our health systems and reveals the social inequalities in our society. I hope throughout this lecture, you'll reflect on your own work in whatever subspecialty you're in, if you're in general internal medicine or some other area entirely, including for those online, and think about how we might apply some of the recommendations I'll show you from our Lancet Commission to the work that you're doing. It isn't just about cancer, I hope you'll see, and it isn't only about women either in all our diversities. So the objectives are to understand the concepts of global disparities in cancer prevention, care, and control, to consider some of the findings and recommendations for our Lancet Commission and some of what's happened since we published it in October 2023, September, and to reimagine what global health might be to advance not just cancer justice, but health justice here in Canada. So I'm going to start by pop quiz. What are the top causes of death globally? I think everyone here probably knows. Anyone? Anyone want to shout it out? I know I can't hear you online. So it's the non-communicable diseases, which are kind of a silly name. They're named for what they're not. And it's a bit of a misnomer anyway, or a false dichotomy, because when it comes to cancer, a full 25% of cancers, especially in low-income and middle-income countries, are actually due to infections. Nonetheless, the non-communicable diseases include cardiovascular disease, which account for almost 20 million deaths globally, and cancers, right? Many different diseases that account for about 10 million deaths. And 18 million of those 43 million deaths, I already caught myself. I said deaths. I should say people who lived and passed away from this condition, died from this condition. People should be central to everything we do. But 18 million of those people were premature at the time they died, which is how the World Health Organization defines premature death, all potentially avertible under age 70. Okay, now the second part of the question is, what are the top causes of death in low and middle income countries? What we used to call developing countries, basically anything other than a high income country. So think China, India, these are vastly different countries with a GDP per capita perhaps as much as 13,000, but a lot of social inequalities in there with billionaires at the top and poverty in the bottom. Nonetheless, what are the top causes? Anyone want to try?
Are you asking?
Yep, 75% of the 43 million NCD's deaths occurred in low-income or middle-income countries, and 80% of those premature deaths due to non-communicable diseases are occurring in the so-called global south, which is really also another word for low and middle-income countries. And that's partly because most of the world's populations are in those countries, right? But as I'm going to show you when it comes to cancer, the top three causes of premature mortality for men and women in all countries except a handful, it's cardiovascular disease and cancer. Usually one is cardiovascular and 2 is cancer. In some cases, it's reversed. There's only 2 countries in our analysis out of 185 where cancer wasn't in the top 3 causes of premature death out of 185 countries. So the good news is we have the Sustainable Development Goals. Now, the bad news is we're doing a very bad job of trying to reach those goals, and we're getting closer to that target of 2030. But we need a multi-sectoral response. That means the WHO, the World Trade Organization, the private sector, all of you, everyone here working in academia, all of us have a role to play to try to drive down deaths from premature mortality from non-communicable diseases by 1/3 by 2030. And we know how to do most of this already. And with due respect to all my amazing colleagues doing immune checkpoint inhibitor research and all the fancy new targeted agents in oncology, we're never going to treat our way out of the cancer epidemic, right? We need to understand the upstream determinants and to work towards the reduction of exposures to all those other conditions: tobacco use, physical inactivity, harmful use of alcohol, or now we might just say alcohol, unhealthy diets, and air pollution. And in cancer, we also have vaccines, highly effective against HPV, which accounts for 4% of all cancers globally. In some countries, cervical cancer is still the #1 cause of cancer-related death. 9 in 10 women who die of cervical cancer are living in a lower middle-income country, completely preventable. We've got Hep B vaccination against liver cancer and H. pylori eradication, which is a big cause of stomach cancer, which is, believe it or not, one of the top causes of death among women as well as men in many countries. But these will require policy interventions, right? I mean, how many people here can say they're doing all the right things? Avoiding tobacco, alcohol, healthy body weight, exercise regularly, yay. Probably none of you feel like you're doing quite enough, right? In all of those, I see people pointing at each other. Yeah. Okay, so the reality is we also need those driving policy initiatives, including sometimes legislation, like the Framework Convention on Tobacco Control, to ensure everyone can actually take advantage of the research that shows us what to do to reduce risk. And where is most of the risk happening? You can see the risk is, the largest in terms of crude numbers in Asia, because it's the largest population. But most of the increase for women, for cancer in women to 2045, is actually happening in the global south. 60% increase in Asia, 60% increase in Latin America and the Caribbean, and check out what's happening in the African continent. 20 years ago, when I started working in global health, the age standardized risks were actually quite low still for many cancers. They're rising so rapidly, more than 100% increase by 2045. Okay, enough about that. Why focus on women, on cancer in women? So when I was a medical student a million years ago, I was taught that women were just like men, only different. So there's a lot we really, really need to unpack. And the point of looking at sex and gender, and yes, I recognize the difference, biological versus social construct, but to look at sex and gender data, right, in every aspect of the cancer ecosystem, including what we understand to be risk factors for cancer, will undeniably help advance efforts to reduce risks and improve outcomes for people of all genders. There's another reason. So here, globally, in 2020, we showed that 9 million women were diagnosed with cancer, and almost half of those died. That's almost half of all new cases and close to half of all deaths. And you might say, yes, but men are more likely to die of cancer. Yes, and men who have a non-sex specific cancer, like colorectal cancer, that occurs almost equally in men and women, do worse stage for stage. But why then are we treating them the same when it comes to clinical trials, when it comes to dose finding, when it comes to understanding the metabolic aspects and the hormonal aspects? And when we looked at cancer under the age of 50, this was Salvo Vaccarella, Freddie Bray, and myself from IARC when I was a senior visiting scientist there before I joined NCI, we found that of 3 million adults diagnosed with cancer under the age of 50 in 2020, 2/3 were women. How did we not know that? And what does that mean for their families and their children? I started asking this question many years ago. 10 years ago, I wrote an article on human rights means sound health equity or some such thing, where I raised a question in a little report. What about cancer orphans? in global oncology, we keep being reminded that we need to do more to use what levers the HIV/AIDS community used in order to advance decreasing costs of cancer medicines and all kinds of things like that. And one of the things that struck me was the AIDS orphans, when they lost both parents tragically. Well, cancer also has its orphans, maternal orphans, which in many places and cultures and customs, and in the case of single parent families, is effectively the same thing. And we estimated with our colleagues at IARC more than 1 million children became maternally orphaned due to cancer just in 2020. And the prevalence of orphans that year was 7 million children. This is important data. It's also a good talking point. We got some media attention around that generated interest in people maybe contributing, especially in the current climate. I just left my position at NIH for a reason. We need people to continue to do this work in women's health, and also, of course, in global health to advance better care for everyone. So there's a scientific imperative here, right? These girls and young women will have higher risks of cancer over their lifetime than we did. Why? Because of these factors I mentioned, and many that we understand very poorly. We don't even know more than about 1/3 of the breast cancer risk. We've got some real breast cancer heavyweights here in the audience in the research side. But we don't know what causes most breast cancer, and we don't understand why it is. Only now we're understanding certain chemicals in products that are marketed to women, particularly like hair relaxers and skin lighteners, especially women of color. Now we're seeing, there might be an increased risk of uterine cancer. Jury's not out on that yet, but there are emerging risks that we really need to pay attention to. But who's deciding what gets studied, funded, right, and published? This is a quick timeline of sex and gender-related research. This isn't about cancer, it's about all research from the NIH. My colleague Sarah Temkin, who also just left, the Office of Research and Women's Health at NIH, and I was working with her closely on a 4-part series on cancer and sex and gender. And we see on the left-hand panel, FDA guidance that excluded women of childbearing potential. Some of you may not know this. This wasn't that long ago, it was the 70s, right? It was only here they started encouraging the inclusion of women. And I see Professor Rochon is here, who has a tremendous expertise in this area. NIH revitalization, 1993. Wow. Only then they started mandating the inclusion of women and women along the lifespan, and sex as a biological variable for all research, all biomedical research, is a recent phenomenon. And you do need to mandate these things in order to see change. Here we have a gender medicine and oncology landmark paper by some of my colleagues at ESMO, the European Society for Medical Oncology, that showed that sex and gender differences influence also treatment toxicities. Okay, so those of you, I don't know how many oncology people there are in the room or online, but let's think for a second. I mentioned that colorectal cancer occurring roughly the same in men and women, and by the way, increasing at younger ages for reasons we don't understand yet, right? We are noting that men tend to do it worse stage for stage. With all this precision medicine, we're not precise about biological sex. And now we're seeing, looking back at older research studies and a meta-analysis on some of the newer research with immune checkpoint inhibitors, we're seeing that the toxicities, not only patient reported, but actual quantitative measurements of white counts, et cetera, febrile neutropenia episodes, are greater in women. So wow, what if we looked at dose finding and toxicity and the way that we do early phase research, looking at sex as a biological variable? Incredibly, we haven't done it. This is the only unpleasant photo I'll show you, but I think it's important. It's also an equity imperative. The photo on the left, I've been using this photo a long time, some of you have probably seen it. The photo on the left panel, doesn't show that well here, is a mammogram from the Ontario Breast Screening Program some 10 years ago. That woman's probably 61. That's the average age of breast cancer in Canada. She has a stage 1 tumor that's relatively easy to treat with a lumpectomy, radiation, and a pill once a day, a aromatase inhibitor or tamoxifen, which is cheap and generic and available everywhere. And on the right-hand panel, I took this photo in my clinic in rural Bangladesh, and this was not an unusual situation. This was the norm. This continues to be the norm in many places of the world, in many cultures. And guess what? It also happens here when we see women who have not been able to seek care. And we sometimes say, and I'm using Nazreen as a composite, story about the many women I saw in Bangladesh over the years, we would say, gee, this is a case of neglected breast cancer. Ah, was it neglected? What does that mean? Well, to the women we asked, they feel like we're blaming them. We don't know why she came then. If we ask and we really listen, and I know they teach that now, and they taught it then too when I was a medical student, I shouldn't say otherwise, but we had a lot to learn. I really had a lot to learn about the importance of not making assumptions. So Nazreen, it turned out, couldn't come because she couldn't afford the bus fare even to get to the clinic, right? Or the other Nazarenes I met came and they were told, this is nothing, ma'am, go home, because they didn't know about cancer. The provider didn't understand. And so on and on it goes. Or the husband said, I don't want you to come back. You go, you don't come back. Breast cancer, very stigmatized in many places, cervical cancer, even worse. And language really matters, right? Why did you present so late? One of my colleagues has done that research. One of my colleagues on the commission, Miriam Mutebi, who's the head of the African Organization for Research and Training in Cancer now, breast surgeon in Kenya. And she did a study that showed that on average, women in sub-Saharan Africa with breast cancer had been to 4 different facilities before they got diagnosed. So this is a health systems issue as well. And then others may have found, here's in Bangladesh, just to give you a sense of where I worked. Khulna division is way down here. It's closer to Kolkata, India than it is to Dhaka, the capital. There's still tigers here. The women who worked with us, sometimes we would drop them off at the end of the workday and they'd be walking into the forest and we'd say, do you want to, like, do you have a flashlight or something? Like, is there somebody going to meet you? And they're like, no, it's okay. See you tomorrow. You know, yeah, Bengal tigers. So not something you hear about every day on your way to work. But what we did have is a lot of women telling us this. When I told my husband I had breast cancer, this is what he said. Yeah. And that is not completely uncommon in high-income countries. Just like the woman with what we might have called a neglected breast cancer is a situation that if you're a breast oncologist for many years, you will see cases like that here in Toronto. I saw them in New York as well from time to time. But the cultural attitudes that make it hard for women to access care, even if they have a clinic to go to and it's affordable, is really what we're going to talk about now for the rest of the talk. If you build it, will they come? I don't like baseball. And I don't like baseball movies, but this was something that always comes to mind. Will they come? Well, they kind of did and they kind of didn't. So we had this clinic in rural Bangladesh near a public hospital. But as you saw, there's 15 million people in the community. It's densely populated. There was only the one public hospital with 2 oncologists and no radiotherapy, right? And so we decided to do a door-to-door interview with community health workers. This was my first major grant I got from Grand Challenges Canada in 2012. And not to go into all the details, but to say that we randomized the community health workers who were young women from these villages, right, who were really keen, but were under or unemployed. And we paid them the same as the government rate. And we trained them in marketable skills, which is part of what Grand Challenges wants you to do, the social innovation, the business innovation, and the technical innovation. And we had a mobile phone with old smartphones with video testimonials so women could hear from their peers who'd been to our clinic directly in their own language. And one of the 2 groups that had the phones also had a half-day training in patient navigation. These were the young women. We had 100 applicants for 30 positions in the first week. And they were just terrific. And you can see here they're wearing, maybe you can't see, they're wearing Canadian flags on their hats because the Canadian High Commissioner, Ambassador Heather Cruden, came and did a ribbon cutting ceremony. But you can see at the beginning, the first day we're talking about breast health to these young women who are not used to having these conversations. They knew what the study was about, but still. And they were pretty shy. And then we realized, oh my goodness, I'm the only non-Bangladeshi person. I was with a female doctor with me. But we had some men in the room. Some of our colleagues who happened to be male were in the room doing this or that. And so we realized this is the first lesson. We need to get rid of the men. So we shooed them out of the room. And this is what happened. It was unbelievable. It was a complete game changer. Just having that sense that we could allow them the space to talk about questions they had about breast health. You know, we enabled them and encouraged them by the end of that first day, actually, to go and examine their own breast if they felt they could. And then they would go and they would report back to us if they had any questions. And many of them had questions. They were young and they had breast cysts, or maybe one of them was experiencing tenderness because of their period, but they hadn't been taught anything about the breast. We were also told nobody's going to answer questions door to door. That's not going to happen. But we'd already worked with the imams in the community to sensitize the population, including the men, that breast cancer was an issue that not us, but our Bangladeshi colleagues who were working in that area, training people to use computers and such, that they wanted to do this project. And first, we sensitized the community. And in 4 months, 30 community health workers interviewed 22,000 women. Okay, it's an old study. Fewer than 1% decline participation. 500 had an abnormal breast exam. And we had this RCT, and we showed that the young women carrying smartphones who also had the extra navigation training for those women found to have an abnormal breast exam, to encourage them to come, because they're all going to say, when you ask them, are you going to come to the clinic appointment? They're all going to say yes. It's culturally inappropriate to say no, as we were taught. And bottom line is, how can we help you come? Can we come back with somebody? Maybe my mill colleague can talk to your husband or your mother-in-law, because the locus of decision-making was not necessarily these women themselves. And we showed a great increase to adherence, 63% versus 43% in the group that was considered more efficient with the smartphones. Meanwhile, in Canada, I was at Women's College Research Institute, working with Dr. Roshan and others, working with Farah Ahmed, who's now at York University, Sheila Dunn, who's now retired from family medicine, and Aisha Lofters, who I hope you all know, doing great work in cancer equity in Ontario. And I took some of the learnings from the Bangladesh situation. I also spent a lot of time in Vietnam at that point. And we asked ourselves, what are the key inequities here in Ontario? And breast screening, we knew, was really, people were under or never screened. It was more likely if you were an immigrant, a newcomer, or from the South Asian community in particular, that I felt close to. I was working with the Bangladeshi Settlement Agency here to educate about breast health. And so we did this various studies, including concept mapping, which was like a systems approach. We did this effort to explore ways to overcome those barriers that the women themselves identified. You can see here, this is a little funny map where concept mapping enables people participating to actually direct the research themselves. So you co-create a rank order of what you think is the reason why you haven't come for screening, and maybe your neighbors haven't come for screening. And then we targeted solutions to bring them in. One of those was simple mobile van. They don't want to travel alone. They like doing things in community, and that really increased the odds that they would come. We also talked about power dynamics and their feelings of not being only about themselves. It's collectivism rather than individualism, but also to emphasize that women are usually last on the list in terms of priority in their own families. And then we moved this into the CARES project in Ontario. This was the Cancer Awareness Ready for Education and Screening project, funded by Cancer Care Ontario in 2012 and 13. And Sheila Dunn led this work, and we did some qualitative research to understand what the conceptions were around breast and cervical cancer. And we also did quantitative work. We did this peer-led multilingual education program, 42 peer leaders and lay educators, who actually, many of them were from the community of interest, of course, but were also physicians or other health workers in their own country, right? Very interesting that this was an opportunity for them to do something with their community and also, again, learn remarkable skills here. And over 18 months, 2,000 women attended these education sessions, provided in 20 languages. We had all kinds of products that came from that. Multilingual videos, we did workshops, et cetera, working directly. And I should say at that point, I was medical director of prevention and screening for Central Eastern Ontario, because my genetics clinic, and that hat included the high-risk population, was at Lakeridge, and my research work was here at U of T at Women's College. So we did this study and we published it in the American Journal of Preventive Medicine after it already left Canada for WHO, that showed after the education intervention, a one-time intervention, the women who had been under or never, they were mostly never screened. Under screened means they're like more than 3 years out without a screen. They were 5 times more likely to have a PAP, which was standard there then, and 4 times more likely to have a screening mammogram versus matched controls with using health data at OHIP and CCO. And at the same time in Geneva, they were, I'm hearing about the earlier days of the cancer system in WHO. They reconstituted after some years of a lot of difficulties at WHO, as I'm sure you know. I was lucky to be a medical officer there for a year with Andre Ilbawi, who now leads the cancer unit with a team of like 20 people, which is going to change soon. But we actually put together a 3-part series in the Lancet. So this was a series of papers based mostly on review and not original research. We looked at just breast and cervical cancer as 2 exemplars of cancer health inequities within and between countries. And the reason I'm mentioning this is because in the middle here, you might not be able to see, Women, Power, and the Cancer Divide was a commentary that accompanied this 3-part series, and it was written by Dr. Michelle Bachelet. Dr. Bachelet was the president of Chile at the time, and we wanted somebody of that profile, you know, a head of state, to potentially write a commentary and bring some attention to this issue of breast and cervical cancer, 2 diseases which we knew were impacting mostly women, and for which we knew a lot about how to protect women from bad outcomes. And the concept of power in the middle there was really something. The other big inspiration that led us to the commission was the work of Professor Anna Langer at the Harvard Women and Health Initiative. She put together a commission for the Lancet several years before that, 2015, called Women and Health, the Key to Sustainable Development. And it was the "and" that got me. It wasn't women's health. It wasn't the health of women. It was women's interaction with the health system. And that got me thinking when I spoke with Richard Horton in November 2019 at the Lancet annual lecture. We had Patty Garcia from Peru, Ministry of Health, teaching us about corruption and global health, which is another huge elephant in the room. And he said, what do you think about doing a commission? Do you feel like you've made enough progress since then? I had already left the WHO. We had started the cervical cancer elimination strategy and the beginning of what became the Global Breast Cancer Initiative. I'm still involved in on the technical working group. But really, I mean, for one thing, that's 2 cancers, and we were looking at the biomedical aspects, right? Including vaccination for cervical cancer. But those bigger questions that we kind of brought up in the series really hadn't yet been addressed. And the power dynamics that influence women's rights and to access care, their opportunities to seek respectful care, and also the way in which health workers are valued, including unpaid caregivers, mostly female, mostly unpaid, right? Many people here in the room probably wear more than one hat, right? They look after patients. They may be a patient. They may be a caregiver to an elderly person or someone else in the family. So we decided to take a holistic view at the nexus of cancer risk and outcomes, social inequality, and the status of women in society. And we had 21 commissioners. We still do. We have, we're still, a commission is about a 5-year project, sometimes longer. About 3 years in is when you publish the report, which is a big research project for those of you who don't know about the Lancet commissions, where you bring people together. Either the Lancet starts it or the commission lead starts it. In this case, it was kind of mutual. And we had a difference in gender, geography, generation. I like alliteration. We had people from North, South, East, and West Africa, all world regions represented. And I also wanted to make sure that we walked the walk. We set a set of guiding principles that were feminist principles from the get-go. So decisions were made by consensus, all the major decisions, and we had 10 mentees who were part of the work. So we'd already be moving to the next generation and empowering them to make their careers, some of them out of this work. 13-person advisory board and a 7-member patient advocacy committee to really hold our feet to the fire, make sure we are asking the right questions in the right way, and that their views were reflected in the final effort, the final report. And we asked questions about sex and gender in relation to cancer risk and survival, who drives decision-making, who provides the care, how are they valued, and how can we ensure equity is embedded into cancer-related policymaking to help everyone. So I'm just going to show you a few slides here. I know we started a few minutes late. Number one, remember I talked about premature deaths? So we did an ancillary piece of work led by one of our mentees, Clara Frick, who did her master's at IARC, the Cancer Research Agency in Geneva, as part of this effort while I was there. And we published that 5.4 million people died of cancer prematurely in 2020, of which 2.3 were women, of which 1.5 million women could have avoided premature death if we implemented equitably what we already know works in terms of primary and secondary prevention. So think vaccination, tobacco control, all the things we talked about, and early detection strategies coupled with care. And another 800,000 women could avoid premature death from cancer if every woman diagnosed. Diagnostics are also a missing link that often don't get enough attention. Every woman diagnosed could get optimal care. And we looked at the way in which discrimination, that's also intersectional, based on race, ethnicity, indigeneity, migrant status, poverty, compound our rights and opportunities, and how we interact with cancer all along the continuum and all along, including cancer researchers and policymakers, as well as people living with and beyond a cancer diagnosis. We had 9 stories in the commission put together by our anthropologist, Carla Kadoff, and my colleague, Dr. Carla Unger in Mexico City. I'll just show you one story. This one's from the US. Self-described, Sally describes herself as a Black gay woman diagnosed in the ER with colorectal cancer. It's never a good thing to be diagnosed in the emergency room. She had had 12 months of care seeking, including seeing 3 different doctors, and said, first she was told, you probably ate something red. She was having rectal bleeding. I don't give drugs to patients, so don't even ask, which she identifies. And I'm sure you all recognize this as pretty common, especially for women of color. I can't help you because you're gay. Unbelievable. This was just a few years ago. Incredibly, she's doing well. Her tumor was large and bleeding, but was stage 3, and she's doing fine now. And she went on to become a huge advocate, not just for women and women with colorectal cancer in her community, but also for the Black community and the LGBTQ community. And we built this story actually in collaboration with the LGBTQ partnership cancer network in the US. And the way she put it, that she wanted to communicate through our report was, I was born this way. I'm sorry if you don't like it. I won't hide for your comfort. I'm here as a patient. Just acknowledge my humanity. All the stories in the report are real stories, and I would encourage you to take a look at them, even if you're not going to read the whole report, because they speak to they humanize the empirical data, and I think speak to all of us. 2 of the stories actually are from health workers, one in collaboration with MSF, with Doctors Without Borders in Mali. So another main point in the report is that in many countries, regardless of geographic region or economic resources, women are simply more likely than men to lack the knowledge. And even if they have the knowledge, I'm sure many women, when I give this talk in high-income countries, they're like, we're the ones who know stuff. We're the ones pushing the men in our lives to get healthcare. But the truth is, even if a woman is affluent, lives across the street from a clinic, and she can afford care, she may not have the power to make informed healthcare decisions. Globally, girls and women are more likely to be illiterate and to suffer to have health illiteracy as well. But it's the power that really features here in terms of information, decision-making, and economics. And those are the 3 domains that we basically concluded were pivotal. And we have a conceptual framework also in the report. Now let's move to the workforce. In the last few slides about the commission findings, women in the cancer workforce, big surprise, like in every other sector, report gender discrimination, sexual harassment, etc. Sometimes by patients, sometimes by family members, and often by coworkers. Women are underrepresented in cancer leadership roles. So we see here from the Union for International Cancer Control, of which Princess Margaret, I don't know if Sinai is a member organization of this large body of more than 1,000 organizations based in Geneva. Of the member organizations that were treatment centers, research institutes, only 16% are led by women. And we also found the top 100 cancer research journals, according to Impact Factor, Guess what percent had a female editor-in-chief in 2023? 16%. You look at cancer research institutes, the NCI-designated cancer centers in the US, and only about 30% are led by women, and very, very few led by women of color. We also looked at authorship, the currency of academia, right? Grants, grant amounts, papers, right? Authorship first and last being, important positions. And we published this alongside a couple of months after this report came out, and we showed of the top 50 countries in terms of output of cancer research, Canada, the US, and the UK were hovering in the 30s in terms of gender parity in first and last authorship. So pretty interesting, right? And that was done over 2 time periods, 2009 and 2019. So the bottom line is that patriarchy dominates cancer care research and policymaking, and those in positions of power decide, right? But patriarchy is not about men, and it's not about women. It's a system of oppression that we all live in, unless you grew up on the moon. And we all have a role to play. And mea culpa, I'm sure I've done that before, of unconscious bias leading me to maybe consider a woman colleague as less qualified or perhaps a grant less worthy. It's important to uncover those biases everywhere, right? So and sometimes women don't hold up, or they hold up the patriarchy and they don't hold up other women, and men can be tremendous allies, as they are, and many of my colleagues on the commission are male. So what are the recommendations? Ensure data on sex, gender, and other factors are routinely collected and reported in all health statistics, right? It sounds so obvious. It's actually still not done to as much as you would think. We have the SAGER guidelines on sex and gender reporting in research, developed by our gender scholar on the commission, Shireen Haydari, who used to be an experimental oncologist turned social scientist. The SAGER guidelines, we did an analysis as well, and we saw that sex and gender reporting should be mandated in the information to authors, for those of you who are writing papers, right? We looked at the top 100 journals, and only about 25% were doing it. Now they're doing it more, partly because of the report. Develop, strengthen, and enforce laws and policies to reduce exposures that we know about for girls and women. And research, monitor, and act on emerging cancer risks, like the ones I mentioned, like hair relaxers, et cetera. We're working with IARC on this and their monograph program, which is all about cancer research, understanding the carcinogenicity and the degree to which something's a carcinogen. Design and implement gender transformative strategies. What does that sound? What does that mean, right? There's a whole area of gender scholarship in health, but it's never been brought into the domain of cancer. And I don't know that it has been for cardiovascular disease, by the way, or other common NCDs. Co-create accessible and responsible health systems that provide respectful, quality care for women. This is being advanced by some of our partner organizations, as I'll let you know about in the last couple of slides. And ensuring equity and access to cancer research resources, right? Leadership and funding opportunities for women. Notwithstanding people here in this room, there are a lot of women leaders here in Canada. And the ASCO Chief Medical Officer of the American Society of Clinical Oncology, the European Society, we've had a lot of female leaders, but this hasn't been the norm, right? There still is that leaky pipeline. And it matters in terms of what we decide to prioritize. Policies to prevent gender-based harassment and discrimination. Of course, we have them here. In many places, that's not the case yet. And Professor Nazik Hamad, who I hope is online, my dear colleague and friend who's now at St. Mike's, she was at Queen's for a long time, originally from Sudan, medical oncologist and education expert, developed a gender competency framework idea for the commission. And she's working on that now through her work across Africa. Develop and validate a feminist economics approach. I never heard of feminist economics, but we had an economics working group. I didn't show you any of the economics data. We actually tried to estimate the value of that unpaid caregiving with a few country examples that are in the report. We also did a mock-up of what an investment case for cancer would look like if you factored in sex and gender. And finally, establishing fair pay. I mean, that should go without saying. And this is so not just about cancer, is it? But we had to say it because our findings kept coming back to those 3 things. information, decision-making, and economics, with power at the center. So we published the report September 2023 in Geneva. We had a lot of people come from permanent missions in Geneva, which is like the UN Geneva, like ambassadors. We had people from the US and many other countries, but we also had a lot of really positive attention. The Guardian had it on the front page, which shocked us. We've had meetings all over the world. We've had national meetings, and we've represented, and I say we really are a collective. Almost everyone on the commission and most mentees have had a chance to present, to talk to media, and to do things that are relevant to their own work in their own countries. And in terms of impact, so far, we had this 4-part series that the NCI did in the US on sex differences in cancer virtual workshop, which was the first one was on biology, the second one immunology, third one on clinical research, clinical trials, which was one of the things I worked on a lot at NCI, and the fourth one on population sciences, which were really well attended. We have the City Cancer Challenge here, which is a spinoff of the Union for International Cancer Control. They got funding from via the Clinton Global Initiative with some splashy event that I couldn't go to last year because at NCI it was too fancy. But they were able to get about $10 million to advance gender responsive healthcare in a bunch of cities as part of this work. And finally, this is an OECD report, the Organization for Economic Cooperation and Development, 38 countries, including Canada, and they used our commission report in their latest economics evaluation for OECD, and I participated in that. And finally, we have a framework for monitoring and evaluation now. To take those recommendations and turn them into actions, you first have to set some indicators that can be monitored and tracked over time. And we've just published that in the Lancet. We also have a course that will soon be available to the public, but right now we're doing this for people who are part of the organization's members to the UICC. So there's a lot to be done. There's a lot we're doing. It's going to take everyone. It takes a village. This is just the people I'm thanking who are part of the commission, including our editors, our monitoring and evaluation colleagues, our many partners. You'll recognize some here. UNAIDS was also a partner. The McCabe Center for Law and Cancer were really the driving force behind the course we're doing. That's all they do, is help other countries' legal experts to galvanize efforts to advocate either for policy instruments that don't exist or ones that should be enforced. And now they're putting a gender lens on the work that they're doing to increase access to prevention and also access to medicines. And I want to thank all the women everywhere who participate and those who bravely share their stories for this report. And a couple of quotes. Sadly, the late Paul Farmer, the idea that some lives matter less is at the root of all that is wrong with the world. And Audre Lorde, noted feminist scholar, who we leaned on a lot for this commission report, without community, there is no liberation. And finally, reclaiming this narrative it's not a one-time act, it's a commitment. Science alone, I'm sure everybody here agrees, is not enough in any domain. It's really only when we commit ourselves to justice as deeply as we commit to discovery that will change the story of cancer for everyone. Thank you very much.
Thank you, Ophira, for an absolutely excellent talk. I'm going to first ask if there are any questions from the audience before opening it up for our remote sites. Just going to see if I can get to some of the remote sites, because I think there is something in the chat. So let me, Barry Goldlist talked a little bit about Dr. Barris. Thanks, Ophira. And please be reminded, okay, are there any questions here in the audience to start? Anybody online? Do we want to just wait for a second? Oh, Michelle Hadanovich has a raised hand. I'm going to try and figure out how to.
Can you hear me?
Yes, we can.
Oh, that's shocking. Okay, I'll get it all started. This was a beautiful talk. Thank you very much. I guess my question is probably an obvious one with the changes that are happening right now at the NIH in the US. how is this impacting this work, which you spoke so much about lenses and feminism and change? And I just want to know how it's going to impact the work for these women.
Thank you so much, and thank you for the question. And yes, is it impacting? Yes, it already is. As I alluded to, I've left the NIH, and some of us felt we had to continue the work, but other people are remaining and trying to keep the work going. I would say that maybe this is an opportunity for us to realize what assets we already have within our networks, within our allyship. There are researchers all over the world looking at, the gender equity in health and other domains coming together now to try to see how we can really leverage these opportunities is what's key. If we're all individually in our silos and trying to write grants, well, that was already fraught to begin with, and now it's going to be impossible for a while. But I really am of the belief, I'm not Pollyanna, for those who know me well, I'm really not. But I do believe that things will shift over time. We're in a terrible period now, but we're going to need all hands on deck for all of this work going forward. So yeah, it'll continue. Thanks.
And maybe just a follow-up is, how do others get involved? I'm doing something similar in Ukraine, for example, is a war-torn nation. So how would you recommend others get involved with the work that you're doing so that there is that power in numbers?
So I'm happy for people, if they want to be in touch with me, and I can share some resources. The UICC, the Union for International Cancer Control, when the Ukraine war broke out, there was a big effort there to fundraise and help channel resources to help people with cancer. I personally have met with a delegation from Ukraine on behalf of the US government at the American Society of Clinical Oncology meeting last year. There's a lot of efforts within the country as well. And MSF, Doctors Without Borders, that I've joined now, we're developing a cancer strategy. So I'm happy to discuss any of it offline. Thanks. Should we? Oh,
Yeah,
you're moderating.
Yeah, sure. There's also one person online, I think, who has their hand up, but first, I think, Steve, do you want to ask him? Yeah. You could say it and then we can repeat it.
If you're a great topic, we have women's hospital, we talk about women's, we talk about cancer in women. So we think about women's cancers in terms of the organ, basically breast, ovary, cervix, fallopian tubes, endometrium. So do you think those are underrepresented in the global research because women's cancers compared to cancers that are either men, prostate, or in both genders? And there's a couple of cancers which occur both in men and women, but are much more frequent in women. I'm thinking of thyroid and believe it or not,
Gallbladder. Yeah.
Gallbladder cancer is like, I think it's more frequent in children than breast. And yet we don't talk about it. I've always wanted to research it because it's so strange and wonderful. But it's a women's cancer too. So have you thought about gallbladder or thyroid as women's cancer?
Yeah, so I think the question for those online was that, we talk about women's cancers as including obviously other gynecologic organs, but there's also cancers that occur in both men and women, but seem to be predominant in women, like thyroid cancer. Part of that's over screening, but still thyroid cancer for sure is increased in women, and gallbladder cancer, particularly in some areas like in South and Central America. So the answer is yes. I mean, there are many important research questions that need to be addressed to better understand sex differences in cancer causation, right? That we simply don't know. The chromosome level, at the metabolomic level, at the microbiome level. Some of the work I'll be doing at Imperial College with Professor Mark Gunter, who was the head of nutrition and metabolism at IARC before he went to Imperial, is going to be looking at some sex disaggregated data on cancers that occur in men and women. But these are, thank you, important questions, and maybe underrepresented in terms of research dollars, perhaps for this reason, that just like we don't understand much about menopause or dysmenorrhea, endometriosis, such a common issue in women, right? And really underrepresented in terms of research dollars. Sorry,
Thanks.
I know we're.
I think this is part of the interest in what Ophira is saying, and part of the excitement that she brings is evident in the time. There's also a lot of really supportive comments online. So I just wanted to highlight that. I want to thank Ophira for an absolutely fantastic parade across an amazing career up until now, and one that will be continuing for many, many years to come. I wanted to recognize also that Ophira is here and has been brought as part of the Barney Barris lectureship that Harvey Shipper spoke about earlier. This is one of the most prestigious professorships at Sinai, and I really want to recognize Ophira for that for that award. And I want to thank everybody for tuning in today. So thank you very much. And I think Ophira is here, but just he's happy to speak with people afterwards. Thank you.